Good morning. Let's begin. I'm Michael Erickson. I'm Dean of the School of Public Health, and we have a great honor of having Sir Richard Peto here from Oxford to speak about some of his work on how to, trivial issue of reducing mortality by half. We had a small meeting beforehand with some of our students and to give them an opportunity to hear some anecdotes from Sir Richard, and it reminded me when I was in graduate school, I had the opportunity to hear Jean Piaget at my university before he died. Not that you're, he was actually telling us, he may want to give you an anecdote about his colleague, Sir Richard Dahl. But in any case, I'm not going to waste his precious time by saying too much, except that, in my estimation, Sir Richard Peto is it's going to sound bad again, the greatest living epidemiologist in the world today, and it's a real honor to have him at Georgia State. He has really transformed. I know he's not agreeing with any of this, but he has. Who would you argue should be?
Henderson.
Well, there we have an argument. No. So in any case, Sir Richard was knighted in 1999. That's right. And I was.
I'll tell you what, she got a sharp sword too. You get so old and grey hair, and you got kneel down in front of a velvet cushion. She comes up to you, and it's a real sword.
So as you can see, my time is short at the microphone. I met Sir Richard in 1994 at an early meeting on global tobacco control at Bellagio in Italy, a conference center that was a very special venue for important topics. And Sir Richard has the notoriety for me of being the only person who's ever interrupted me when I was introducing myself. He corrected my introduction, which I found to be phenomenal that could happen. So Richard's a bit of a...
20 years later, I apologize.
22 years later. In any case, we're honored to have Sir Richard here. I'll turn it over to you. I had to mention that I have to leave midway. We have our advisory board meeting today, but I do want to appreciate CDC for making Sir Richard available while he's in the United States. He's heading to, is it New Orleans, Florida?
Yeah,
New Orleans for the American Association of Cancer Research to receive an honorary award. So he's fitting us in on his U.S. travels, and it's an honor to have you here.
Well, thanks very much. Thank you.
Now, what I want to do is to just run through epidemiology, just stating everything which is obvious. So all the things I'm going to state are going to be obvious. I want to deal with the obvious things, because the obvious things are the ones that account for the big numbers of deaths. And you can prevent more deaths by a moderate reduction of big cause than by a big reduction of small cause. So boring, old, obvious causes are more interesting. Now, my question is, can we halve premature death? And I'll define premature death as death before age 70. That's great, because that means I'm completely safe. There's no problem. And in case I don't say what I mean to, there is a one-page article which says what I was going to say. That's only 600 words long. And then there's a 14-page article that says the same thing at greater length. So and I'll leave this talk behind. It's available electronically for anybody who wants it. And I've tried to put references on the various slides so that if you want to look things up, then you can. And I'll point out there's one slide I'm showing from the Global BMI Consortium, which is of a paper by other people, which is still in press in the Lancet. They've got the proofs back, but it isn't out yet. So that's confidential until it's published in the Lancet. But again, it's looking at BMI and death. That's not so revolutionary, but it is just the best analysis of it that's been done. Okay, so the death in old age is inevitable, but death before old age is not. If you reach old age, you're going to die in old age. But the deaths before old age, whether they're deaths in childhood, deaths in early adult life, or deaths in middle age, these are mostly avoidable. We're not going to get 100% survival to age 70, but we could reduce and we could reduce by half within 20 years or so the probability of dying before age 70. Now, if you're going to avoid dying before 70, you've got to do three things. You mustn't die in childhood, you mustn't die in early adult life, and you mustn't die in middle age. And these are separate things because the causes of death in childhood and the causes of death in middle age are very different. And it doesn't matter exactly where I put these cut points. I mean, because under 5 mortality has been so widely discussed, I've defined childhood as ending at 5, but if I defined it at ending at 15, it wouldn't be very different because the causes of death at ages 5 to 14 are very similar to the causes of death at ages 1 to 4. So you want some sort of cut point that gets childhood, and I don't care where it is. Then you want some sort of cut point that gets middle age, and sometimes I'll stop at 35 and sometimes I'll have this cut point at age 50, so it doesn't really matter which. So let's go forwards rather than backwards. So I don't care where these cut points go exactly, but there are 3 separate age ranges where we've got to consider avoiding premature death because the causes are so different. Okay, so if we take these age ranges to start with, say 0 to 4, 5 to 34, 35 to 69, how many deaths are there worldwide in these age ranges? I'll do number of deaths first, crude numbers of deaths, and then I'll talk about probabilities of death in these age ranges. Well, if we take 2010 death rates, then roughly we've got about 7 million deaths in early childhood, then about another 5 million deaths before age 35, so 12 million total, and then about 18 million deaths in middle age. So a total of 30 million deaths before age 70. And you can learn that figure, 30 million, and remember it because it's going to be true for the next 20 years or so, certainly the next 10, 15 years. And the reason for that is global death rates are going down quite steeply, but the population, especially in middle age, oh yeah, could everybody turn their mobile phones off, please? I've turned mine off. But the population in middle age is going up. So we've got the death rates per person going down, the population going up, and these approximately counterbalance each other. So the rate of decrease of mortality and the rate of increase of population, for the moment, they happen approximately to cancel each other out. And so this number of about 30 million deaths a year before age 70 is going to be true throughout the 2010s and the 2020s, something roughly like that. No matter what we do, we can do a bit better than average, we can do a bit worse than average. Now what I want to do is to look at some trends in mortality, and I'm going to start off with trends in mortality over the last 100 years in Britain. Then I want to look at trends in mortality over the last 40 years worldwide, and then I want to look at cause-specific trends in the last 10 years, in the period 2000 to 2010, saying what is happening to global mortality rates, what's happening to child mortality rates this century, 2000 to 2010. So I want to start off with a 100-year span, then a 40-year span, then a 10-year span. So we'll start off with a 100-year span. So I want to look at death rates in England, strictly actually as England and Wales, in 1910, in 1960 and at 2010. And what I mean is the death rates, the mortality patterns at the death rates of 1910. I'm not saying what happened to people born in 1910, because if they were born in 1910 and they survive 50 years, then they'll have 1960 death rates. So I'm saying what would happen if 1910 death rates applied. So it's the death rates of 1910, the death rates of 1960, the death rates of the year 2010. And here they are. So, and I want you to look at the probability of death in early childhood and the probability of death before age 70. So 1910, my mother was born in 1909. My father was born in 1902. So, this is my parents' generation. It's probably your grandparents' generation. But about 1 in 6 would have died in early childhood. Now that is much worse than the average for low-income countries nowadays. This is England. This is one of the most prosperous countries in the world in 1910. and yet the child mortality is much worse than we now see in the low-income countries of the world. So child mortality was about 1 in 6, and by 1960 death rates, we were down to about 4%. So we've got 4% of the kids are dying in early childhood. And now, at 2010 death rates, we're down to about 0.4%. We've had a tenfold reduction between 1960 and 2010. We're having the kids in circumstances where birth is safe. We're vaccinating them. We're not exposing them to all the sort of pathogens that were around. And if they do get ill, then we've got a lot of intensive treatment with which to manage those illnesses and, with a bit of luck, cure them. So the ones who do die are mostly the ones that are born with something so catastrophically wrong with them that there's nothing that modern medicine can do to save them. Sure, some of them get murdered, some of them this, that and the other thing, but it's mostly disease. So we've gone from 1 in 6 dead in early childhood to 4% and then 0.4%. But look at age 70. Here we had 2/3 dead before 70. Then we got about 1/3. What is it there? You've got something like, well, what is it? It's more than 50%. So nearly 50%. And now it's only about 20%. Now this is males. And I've done males because males got hit by smoking harder than females. And so by doing males, I want to then talk a little bit about smoking. And then later on, I'll come back to what happens in females as well. And a lot of the graphs I show will actually just mix males and females up together and just take people. So we got, early in the century, there was a lot of child mortality, quite a lot of mortality in early middle age as well. You know, by age 50, you can see you've got about 1/3 have died. So 1/6 dead in early childhood, 1/3 dead by age 50, and then 2/3 dead by age 70. But even if we take the period 1960 to 2010, there's still been quite a change. I talked about that change from 4% to 0.4% child mortality. But you look here, there's about a 10-year difference. And the reason for that is because in 1960 and in 1970 still, British men had the worst death rate in the world from tobacco because we'd started smoking first. So we had the highest death rates in the world from tobacco. And then, you know, since 1970, we've had the best decrease in the world in tobacco deaths, but it's quite easy to have the best decrease if you start off with the worst death rates. What happened, the next picture looks like a lot of cigarettes, but it isn't. See, you've got all these are bar diagrams, and at 1960 and still at 1970 death rates, this says if you've made it to age 35, what's the chances you're going to die before 70? And it was, you know, 1970 death rates 41%. And 19 of those 41 deaths were from tobacco, and that's assuming that some of the vascular mortality associated with tobacco wasn't caused. If you put in all the vascular mortality associated with tobacco, that'd be about 23. So something like, and probably the 23 is nearer the truth. So, you know, half the deaths, basically half the deaths of British males at 1970 death rates were from tobacco. And since then, the death rates have gone down by half, and the chief thing driving it down has been the reduction in tobacco deaths. Now, the reduction in tobacco deaths has been helped by all the wonderful medicines for heart disease we've got now. You know, because if the heart attacks caused by smoking are treated and don't kill you, then you don't get killed by then the tobacco didn't kill you. So it isn't just anti-smoking propaganda with no help from medicine. And the death rates of non-smokers have gone down too. Sure, things are getting better, but of course the biggest driver in Britain, because we had such high death rates from tobacco, has been the decrease in tobacco deaths. Now, I'll show you now what you would get. I'll show you a similar picture, but now instead of putting part of the mortality from tobacco, of the vascular mortality from tobacco, I'll put in all of it. Let's assume that all of the excess cardiac and stroke mortality in smokers is causal. Then we'd get this. Same sort of thing. So this is the 23 that I talked about. So, and this is 1950s, 1960s, 1970s, 80s, 90s, and in the present. And that's a projection. But we've got data out to about 2013. And it's the same thing. The way this differs from the previous graph is that this graph assumes that all of the vascular mortality associated with smoking is caused by smoking, which probably is nearer the truth than assuming half of it is, which is what the previous picture assumed. Okay, what about women? Well, women epidemiologically are not nearly as useful as men because they don't smoke as much, and anyway they've got lower death rates than most other things except breast cancer. And so they're not as useful really as a subject of study, but for what it's worth, there's the female tobacco epidemic increasing. It had its maximum in the 1980s, 1990s, but it too is decreasing. So now men and women have rather similar death rates from tobacco in Britain. You know, the decrease in both sexes, but particularly this huge decrease in male deaths. And so now if you plot survival curves, 2010 survival curves for male and female, there's only about a 4-year difference between them. And of course, in old age, we still do have a lot more male tobacco deaths than female tobacco deaths. But it's a big change. It's a big change. And we've got to the point now where instead of 1 in 6 dead in early childhood, we've got 1 in 6 dead by age 70, put the male and female together. And it's an extraordinary change. And in some ways the 20th century is the century of the dead, but also it's this, look at the wars, 200 million killed in wars and famines caused by wars and political disturbances. But, look at the avoidance of child mortality. And what happened in rich countries in the first half of the century happened worldwide in the second half of the century. So if we look at child mortality worldwide, under 5 mortality worldwide, well, the statistics for 1950 aren't so reliable, but something like a quarter of all the kids born in 1950 would have been dead before their 5th birthday. By 1970, the world was where Britain was in 1910, with 14%. And that improvement was the result of definite efforts. And then at 1990 death rates, 9%. 2010 death rates, about 5%. That's the 7 million deaths. And these changes have been brought about by huge efforts to get vaccination to happen, to get antimalarial treatment to happen, to get diarrheal treatment to happen, to actually get pneumonia treated, to have clinics available that will provide some kind of treatment. And still, there's 7 million deaths and there shouldn't be. But still, things are much better than they were. So and what I want to do now I want to jump over to the last 40 years. So I've marked this red, and everything I show for the next quite a long time will be looking at the trends in mortality between 1970 and 2010. And there are some horrible exceptions, but overall, they're remarkably favourable, with some horrible exceptions. So that's just child mortality. So remember this number, it'll come back again, 14% under 5 mortality down to 5%. And a reasonable target for 2030 is 2%, 2.5%, something like that. Certainly sometime by the 2030s, it ought to be possible to be down to 2% under 5 mortality everywhere except where you've got war, civil disturbance, things like that. If you're in the middle of the Eastern Congo, then God knows what the child mortality is. But in places that aren't in dreadful circumstances, then it should be possible to be down at 2%, at 1/10 of what it was at 1950. Okay, so, right. These are the same as the survival curves. This is for the world as a whole, and it's just the same survival curves you saw for Britain, but turned upside down. So instead of starting all alive, this is now the proportion dead, so you start off with nobody dead. And the top line is 1970 survival patterns, and the bottom line is 2010 survival patterns, and there's that child mortality, 14% down to 5%. But, look at the probability of reaching age 70. It's gone from 54% down to 36% dead before 70. And these red marks here, this is England in 1910, England and Wales in 1910, and this is England and Wales in 2010, so 18%. If we were going to halve premature death worldwide, then we need to get that 36% down to 18%. Can it happen? And by when can it happen? So 54%, 36%, 18%. What needs doing? Well, keep on getting the child mortality down, but there's only so much more that you can do. You can get that down to 2%, but we've got to do something about the mortality, particularly the mortality in middle age. It won't make much difference, the probability of surviving beyond 100. When you get to 100, it doesn't matter very much. You're not very expensive because you're going to die so soon. I mean, at age 100, the annual death rate is 50% per year, so life expectancy is 1 year. So, you know, the expense isn't having lots of centenarians. And of those who reach 100, like 1 in 1,000 will reach 110. You know, if you've got 10 years, and every year you've got a 50% chance of dying, then you've got a 1 in 1,000 chance of living 10 years. So we're not going to get a lot of centenarians in absolute numbers, but there will be a lot more people who are alive in their 70s and in their 80s. And obviously, there are problems, there are disadvantages in that, and there are advantages. I mean, speaking of somebody in his 70s, being in his 70s can be quite enjoyable, as long as you're not, you know, seriously ill. So that's world mortality at 1970 death rates, 2010 death rates. Now I want to look at the trends in various different places. But I want to look at the death rates in childhood. I want to look at trends in child mortality. Then I want to look at the trends in what's the probability of 5-year-olds going to die before 50. Then I want to look at trends in what's the probability that a 50-year-old's going to die before 70. So I'm now going to use these 3 age ranges: under 5, 5 to 50, 50 to 70. Okay. Now, I'm sorry, I should not have plotted 0 to 49. So will you just look at the blue, the red, and the purple in what follows and ignore the black lines? Black just puts together child and early adult. So forget that. Just look at the 3 age ranges. And each of these lines goes from 1970 to 2010. And look, they've all got a sort of head on them, and they all look like little sperm swimming into the future, okay? Now, and I'm going to show lots and lots of pictures with swarms and swarms of little sperm. And every time you see one, the head is 2010 and the tail is 1970. So there you've got world under 5 mortality going down. There you've got world mortality at ages 5 to 49, which would include most of the HIV. And it's going down, but it's stalled because of the HIV epidemic. It should have gone down to about here. Instead, it went to about here. And as HIV treatment is used, this is going to go down and catch up, do a lot of catching up. Then we've got 50 to 69, and it is surprising how much that's improved. It's gone from 36% of those who reach 50 dying before 70, down to 24%. It's gone down by a third. Death rates in middle age are going down, not up. When we talk about the global NCD epidemic, remember, death rates from NCDs are going down, not up. When we, just death rates, total death rates are going down, death rates from NCDs are going down. And that's a substantial change over a 40-year period. So looking historically, things are getting better. Maybe not fast enough, but they're getting better. Now, obviously, countries aren't all the same. We split the world into low income, high income, and middle income. And the way the World Bank does it, we finish up with 1/6 low, 1/6 high, and 2/3 middle. So when they talk about middle income countries, that's 2/3 of the world's population. And so they tend to split middle income into lower middle and upper middle. So it's low, 1/6, lower middle, 1/3, upper middle, 1/3, high, 1/6. And that's the way the World Bank divides the world. And obviously, the child death rates are much worse in low-income countries than in high-income countries. So if I take these now and split them, then here's the low-income countries, and here's the high-income countries. And here you can see, look, 3% down to about 0.4%, something like that. Early child mortality, under 5 mortality in the rich countries of the world. But then look at the poor countries in the world. Look how big the improvement is. 23% down to 10%. So in absolute terms, much the biggest gain is in the low income and the lower middle income, because they had high death rates to start with. Here you can see the effects of the HIV epidemic much more clearly. You can actually see it in the high income countries too. As you know, America got hit quite nastily by HIV, but not as badly as Southern Africa. But overall, the pattern in each of these groups is favourable. with that HIV exception, which with treatment should stop being so exceptional. But look at the purple lines, the mortality, the probability that a 50-year-old will die before 70. Again, low income, middle income, high income, it's favourable in each area. Now, again, this is too crude. The world has 200 countries in it, and actually, you know, particular countries have different regions in them, and particular countries have the rich and the poor in them, and different populations. So, you know, this is all too crude. This is, you know, a sixth of the world, a third of the world, a third of the world, or a sixth of the world. You know, what do we find when we subdivide it a bit? Well, we can subdivide it into countries, but there's 200 countries, so it becomes impossible. But if you look, the 25 most populous countries contain 75% of the world's population. And so if we just take the 25 most populous countries, you know, America, Britain just makes it in, Russia and China and India, then they will give us 3/4 of the world population. And on average, what's happening in the 75% in the 25 most populous countries, and in the, you know, more than 100 other countries put together, is the same as the global average. So we've got a fairly representative split of countries if we just look at the 25 most populous ones. So what I'm going to do now is look at under 5 mortality in the 25 most populous countries, and I'll sort according to what it now is. So, okay, 75% of the world's population live in the 25 most populous countries, so we'll now look at the trends starting with child mortality. So here we are. Again, each line takes us from 1970 to 2010. Well, of course, here's Bangladesh, where you start off with a horrible war around 1970, and then, you know, so you're going to get some improvement. But, you know, here's Egypt. They didn't have a war in 1970, at least nothing that killed many kids. And there's been, 23% of the kids dead, down to about 3%. Iran. Look at that reduction in child mortality in Iran, in Turkey. A lot of places think, and here are the rich countries, but you see Russia, I mean, a lot of the things went wrong in Russia, but child mortality went down. Here's the United States, United Kingdom, France, Germany, Italy, Japan. I mean, it's an extraordinary pattern. And almost everywhere, South Africa had such a catastrophic HIV epidemic that it actually affected under 5 mortality. And so you get this kink here. But, you know, most HIV isn't killing the under 5s, it's killing young adults. So it'll come into the next age range. But that's the HIV epidemic being so bad in Southern Africa, it actually affects under 5 mortality. And here, in the Democratic Republic of the Congo, you know, you're not making progress because you've just got war all the time. So this is the effects of war, this is the effects of HIV. And you've got to also say, how do you know these numbers? Who was counting? How do you know what the death rates were? Well, you don't. And if you're epidemiologists, you should be skeptical. These are the World Bank's, these are the United Nations Population Department's estimates. They've got quite a lot of indirect demographic methods of trying to estimate under child mortality. You know, you ask women how many kids you've had, ask them when they died and so on. Well, women remember. As long as you're not looking at an area where everybody got wiped out, for example, by a famine, then you can actually ask mothers how many kids they had and whether they died. And these sort of methods have been being used. Demographers have had methods for trying to estimate overall mortality patterns for a long time, and they're not perfect, but they're not bad. And if you see something that really looks out of line, then say, well, is this a case where the methodology went wrong? But in general, I think that the overall picture is trustworthy, even if the detail isn't. Okay, which of these countries? Well, these ones are the African countries: Congo, Nigeria, Ethiopia, and South Africa is here. Then what about the biggest countries? Well, there's India. Look at the change in Indian under 5 mortality. There's China, 10% down to 3%. And I mean, they're claiming that it's to the nearest whole number now. It's 1%. Well, good. And there's the United States. So those are big countries. But then, look, what on earth were the generals doing right in Myanmar that produced these changes? You don't need to do much to reduce child mortality. It's not a lot. So, so there is heterogeneity there, but there's also overall remarkable progress. Now, what about the next age range? That's quite different. Okay, here are the African countries, and here is South Africa. And the death rates in South Africa were going down. Then the HIV epidemic hit, and they shot up. That's HIV, and then that's the beginnings of HIV treatment. So, and this is going to come down a lot by the 2020s. So that's going to really be down if the HIV treatment continues to be given and continues to work, which it looks as though it will. So, yeah, this is war and HIV up there. Here you've got Iran. Now, in South Africa, if you did that, this is male and female together. If you did it for females only, it'd be even worse, because the HIV was hitting the females worse than the males in South Africa. Here is Iran, that enormous spike there. This is where Saddam Hussein invaded Iran and killed 1 million male Iranian soldiers. If you do this for females, you just see uniform improvement. If you do it for males, you'll get a spike twice as big as that. But it's just, that's, again, it's the effect of war. This one is a bit surprising. This is Thailand. I thought that was HIV epidemic when I first saw it. But actually, in Thailand, you've not only got an HIV epidemic, but you've also got a huge increase in accidental deaths from drunken driving, particularly of motorbikes. If you say, what's the probability that a male in Thailand is going to die before 50 from an accident, accidents or violence, it's 5%. You know, and it just shouldn't be anywhere like that. And a lot of it is that Thailand's got the highest traffic accident death rate in the world. As, you know, there's claims that Libya does, but if you take Libya as saying we don't know what it is, then Thailand is the worst in the world for traffic accidents, and it doesn't have to be. But, you know, there's got to be something done about drunk driving and motorbike deaths, and also quite a lot of violence there as well. And then here's Russia, which I'll come back to soon, which, I mean, that's actually vodka. But where are the big countries? Well, look at the improvement in Indian mortality. What's the probability that a 5-year-old is going to die before 50 in India, in China, in the United States? And these are sorted by where we've got to. Look, China is now doing better than the United States. That's an interesting statistic. And then you get France, UK, Germany, Japan, Italy. Well, it's interesting. Italy actually beats Japan in that age range. But, and again, it's basically things are getting better unless there's a catastrophic reason for them getting worse. And again, there's Myanmar, there's Russia. Again, you know, what were they doing right? Then we'll take what's the probability a 50-year-old will die before 70? And here are the African countries, really not much progress. And this, you know, Nigeria, South Africa, Democratic Republic of the Congo. This is Russia, with death rates comparable with those of sub-Saharan Africa, even though it's an industrial country. They shouldn't be anywhere near there. And this is due to male mortality from vodka. That's the key thing driving that. And then there are some, I don't know what to make of this one. Here's Egypt looking rather unpromising. Here's the Philippines looking rather unpromising. And you know, you wonder if those are statistics where, you know, you check the statistics on the countries that look out of line. And there's Iran looking remarkably promising. Again, I'd like to check the statistics on those that look out of line. But the general picture, I think, is trustworthy. The general picture is trustworthy, and it's basically getting better. There's, again, the big countries, India, China, the United States. And there's Myanmar and Russia. And Russia, when Russia collapsed, work disappeared, the prices of things increased enormously, the state collapsed, it was so totally demoralized that even the birth rate collapsed by half. You know, what does that tell you about what was happening in the population? And, you know, the price of food went up, the price of vodka went down. All the communist controls on vodka consumption disappeared overnight. And you've just got total moral despair. And for 10 years, they just had this massive death rate from vodka. And since 2005, they've begun to reduce it, but it's still pretty bad. I mean, we did some studies in Russia. In fact, we did a study in Russia where we went knocking on the doors, and you know, after people had died, and said, "Excuse me, you know, did Dead Fred live here? And you know, would you tell me what Dead Fred used to drink? And you want to know what a Russian man drinks? Ask his wife after he's dead. She'll tell you, bastard. You know, 2 or 3 bottles of vodka in a session he'd drink." And so, if you take the ones who are averaging about a bottle of vodka a day, which actually means 2 or 3 bottles of vodka every 2 or 3 days. They had about 4 times the risk of dying of traffic accidents, 6 times the risk of dying of other accidents, 8 times the risk of committing suicide, and 10 times the risk of being murdered. And for the females who were drinking a bottle of vodka a day, it was 15 times the risk of committing suicide and 20 times the risk of being murdered, because, you know, drunken men and women hang around with horrible drunks. I mean, it's a disaster. But it is getting better. Since 2005, it's gone better. The Russian death rates have gone down by about a third in early adult life. Well, they need to go down by quite a lot more before they finish up as West European death rates. So there's a particular reason for that. It's the particular catastrophe, as well, the demoralisation and catastrophe that went with the collapse of communism. I'm not saying communism should still exist, but when it collapsed, the chaos with which it collapsed was just awful for the people living there. Even if you had any money saved up, then unless you're an oligarch, it nearly all disappeared because it was 2,500% inflation, so you'd lose 96% of it. Okay, so basically, in some populations, for example, China, tobacco is getting a lot worse. In some populations, for example, Southern Africa, HIV has got a lot worse, so now it's getting better. In some populations, like Russia, alcohol's got a lot worse, although it's now getting better. In some places, you've got adiposity, Mexico, for example, where there's a big increase in adiposity and diabetes. And in various places, you've got war. But basically, if you take out the places where some particular thing is going wrong, overall, things are getting better. Non-communicable disease, communicable disease, even accidents and violence, if you're avoiding the places which are dominated by war. And, you know, yeah, sure, Thailand's got worse, but there are other places where the traffic death rates have gone down. So overall, things are getting better. So now I want to come back to what do we have now, and I'll look at 2010 death rates. What are these deaths due to? What are these deaths, what are they due to, and can they be halved? Well, those 7 million deaths, the first thing is about 2 million deaths in the process of actually being born. So perinatal, neonatal. There's, they used to have a sign up in the hospital in Oxford saying that, you know, in the obstetrics department saying, you know, be careful, the first 10 minutes of life are the most dangerous. And somebody wrote underneath, the last 10 minutes aren't too good. Anyway, so, and then these are to the nearest million, about 1 million pneumonia, about 1 million diarrhea, about 1 million. Now, each of these is actually less than 1 million. To the nearest million, yes, they're 1 million, but actually they're now all less than 1 million. And if we went back to 1990 death rates, they'd be about 3 million, 2 million, and somewhere between 1 and 2 million. So they are going down. Things are getting better. But these are things where people can do things to actually make things change. External help and internal help. Countries need to get things organised themselves, and external help can help them do that. And you need to use medicines. We need to use medicines and vaccines. The observation that in the West, death rates went down not mainly because of better medicine, but because of cleaner water and vaccines and things like that. Yeah, look, and this is sometimes put up as evidence that medicines and so on are not the key to reducing mortality in poor countries now. They are. And the argument that because 100 years ago, when the drugs we had were bloody useless drugs didn't make much difference, is not a good argument for saying that good drugs, which we now have, don't make a difference. We had useless drugs 100 years ago, and so, yeah, the big decrease in mortality was not caused by the use of those useless drugs. We now have very good drugs and vaccines, and they have a lot to offer in terms of reducing mortality. And so the claim that because in the West, death rates went down by social progress of various sorts and clean water, actually a lot of effort to make things better, does not mean that medicines and vaccines and the interventions that we now have are inappropriate, ineffective nowadays. Okay, so what about the next age range? Well, 5 million deaths a year at ages 5 to 34. 2 million of them are injuries, accidents, violence, suicide. About 1 million HIV disease, 2 million other disease. Well, this can be reduced by treatment. These vary over time. They change from one time to another. They're not fixed. Suicide rates aren't fixed. Traffic accident death rates aren't fixed. Society can do things about them. We can't get rid of traffic accidents. Traffic accidents are more than 1 million deaths a year worldwide if you take all the age ranges. But you can do quite a lot to reduce traffic accident deaths. Partly treatment, partly various safety things. And again, you don't have to have high suicide rates. There's great variation between one place and another in suicide rates. And that means, and also from one time to another, and this speaks to avoidability. There are things that society can do that will affect the suicide rate. There was a huge spike in suicide in Russia after communism collapsed. But again, so these are, but it's more difficult to halve mortality in this age range. When we get to the next age range, half the deaths, we've got 18 million deaths, half of them are vascular disease, heart attack and stroke, or cancer of one type or another, and about 4 million would be other non-communicable diseases. So 3/4 in total would be non-communicable disease. And that's what I want to talk about really, as to what can we do. 3 million communicable, and it's because I've taken the age range down to 35, there's quite a lot of HIV in there at say 35 to 49. If when we're looking at the distribution of 60 to 69, then it'd be basically non-communicable disease plus TB and pneumonia, and that's about it. So we've got TB, pneumonia, HIV, and then still quite a lot of deaths from injury, accidents, not so much violence in this age range, and also suicide. But the question then is, can we halve death rates from non-communicable disease? What things really matter? Well, obviously, I'm going to say smoking matters, I would. But what else? So the question, if we're going to halve mortality in middle age, then we've got to do something big about vascular mortality and cancer mortality. Can we do so? Well, in Britain, vascular mortality is going down extraordinarily fast. So we've had, if we take 90, look at this graph, it's absolutely beautiful. Now this is UK vascular mortality death rates. Females down here, males up there, and it just isn't fair, you know. And of course, the decrease in male mortality has been helped enormously by the decrease in smoking. Still, smoking is a serious cause of death in Britain. It's more than 20% of all the deaths in middle age, but it used to be about 4 times as big as a cause of death. So we've got a much bigger decrease in tobacco deaths in men than in women, but we've also got drugs that work. We didn't have any drugs that worked. If you go back to 1980, what have we got that works? We've got some rather ineffective blood pressure lowering drugs. We don't have good evidence on aspirin. We don't have statins. We don't have angiotensin receptor blockers, ACE inhibitors. We don't have clot busters. We don't have a lot of the vascular surgery we've got now. So there's a lot of medical things that have actually helped these things down. And of course, that also reduces tobacco deaths. So death rates are going down, but here, that cross is the average of male and female, and that would be 16% dead. Here, the average of male and female is about 4% dead. It's, well, it's an amazing change. It's about a 4-fold difference. So we've been halving mortality every 15 years. You haven't been doing quite as well in the States, but still pretty well. I apologise for the fact that these pictures are on different scales, so be careful of the scale. So here's the picture you just saw. There's Britain, United Kingdom, vascular mortality, male at the top, female at the bottom. And here, on a different scale, so watch out, is US vascular mortality. Well, you know, sure, we've gone down, and this goes a little bit beyond 2010. So we're down to about 5% male and, I don't know what it is, about 2% female. It's just really, we're down below 4% now, if you take male and female as an average. And in America, it would be, what, about 6% or something like that. But still, look at the reduction. You know, can we halve vascular mortality? Well, we've done it. We've done it pretty well over the last 40 years. It's gone down to 1/3 of what it was. Here, it's gone down to 1/4 of what it was. And it could continue to go down if we can do things about, particularly, we don't want increases in the adverse effects of adiposity. If people do get diabetes, then we want that diabetes treated effectively. Otherwise, you get big excess mortality in diabetics. And we want widespread use of medicines that work. So can we actually reduce vascular mortality? Well, bear in mind just how much it's gone down. If you just look too narrowly at the present and forget the past, then it seems impossible. But actually, if you look over a period of decades, a lot is possible. Now, one thing that we do need to do if we're going to get world vascular mortality down is to get generic, affordable, effective drugs widely used. Drugs work. When Geoffrey Rose had his sick populations and sick individuals thing, he was talking at a time when he didn't have drugs that worked. We do have drugs that work now. We have drugs that can really substantially affect national death rates, but they won't work if they're not used. And I think the place to get in with use is in people who've actually got some disease already. They've had a minor heart attack, they've had a minor occlusive stroke, they've got diabetes. They don't want a serious heart attack, a serious stroke. They don't want the diabetes to progress on to renal disease. Well, use the drugs that work. Statins, if we take atorvastatin in Britain, 20 milligrams of atorvastatin a day in Britain, I don't know what the price is here, but it's $2 a month, $24 a year, drug costs. And you don't have to keep on seeing your doctor. And it's, you know, just, if the doctors would just stop testing people and just give the pills. I mean, if we could just take away every sphygmomanometer from every doctor and every hypodermic syringe, so they don't test the blood pressure and they don't test the blood cholesterol, and they just give the pills, the patients would probably be better off. I mean, that's arguable, obviously, but there's some truth in it. Just make sure that whatever else happens, people do get medicines, they get offered medicines, blood pressure lowering drugs, generic. Thiazides, they're so cheap, they're cheaper than aspirin. And then there's aspirin also for people who've actually had an occlusive vascular event. So this is practicable in high-income populations. It's not happening enough. It's also practicable in middle-income countries, even lower middle income, where you've actually had occlusive vascular disease diagnosed. So if there's enough medication, if there's enough doctors around to actually diagnose occlusive vascular disease, then there's enough to actually give these pills. And if you try and do it through hospitals, it won't work. We've got to have outreach. You've got to have outreach. I mean, I'd rather have these things prescribed through pharmacies than through clinics in a lot of places. We need to work out how to actually get the things that work to be used. They're cheap. Will polypharmacy help, bundling things into one drug? Well, into one pill, they might. It might. We just want what's practicable. And it's going to be different. The things you've got to do are going to be different in different countries. The problems of getting drugs used in China, in India, in Egypt, in the United Kingdom are different. But the aim should be to treat high risk. If statins, say, I gave the example of 20 milligrams of atorvastatin, I have no interest in any drug company at all. It'll knock about 40% off your risk of vascular disease, something like that. So, and if you've got a big absolute risk, then knocking 40% off, it's worth doing, certainly not more than a third off. And if you were using just generic, you know, ACE inhibitor and diuretic, that'd do something similar. Use them together with a statin, you're knocking more than half off your risk. So you can, it's easy with cheap medication to knock more than half off whatever risk you've got. So, and that you get greater absolute benefits than you would in primary prevention, unless it's primary prevention in somebody who's very high risk. But it's the high risk who get the greatest absolute benefit. And you don't need a screening program to find out how to treat. You don't have to medicalize apparently well individuals. So I think that should be a starting point. And then, yes, some primary prevention as well, some treatment of people who haven't had events. How much, I don't know, but we're not getting this done yet. You do surveys in China, you do surveys in India. People with a history of occlusive disease are not on effective medication as a general rule, and they should be. So secondary prevention, I think, should be part of how we're going to get something to happen worldwide. What about causes? What about primary prevention? Well, big causes: tobacco, blood pressure, blood lipids, being too fat. Let's run through them. I'll give 1 or 2 slides on each. Tobacco. Go back. Now, this is Valerie Browell's Million Women study. She asked 1 million women in Britain, you know, what they smoke, follow them up, and see who dies of heart attack. So here's heart attacks. If you're a light smoker, then you have 3 times the risk of dying of a heart attack in middle age that a non-smoker has. So don't worry about heavy smokers. I don't care about the heavy smokers. The light smokers triple their risk of heart disease. The light smokers double their risk of dying from stroke, and also a lot of non-fatal stroke as well. And you know, so I mean, smoking, if you're a light smoker, then you will double your risk of death from vascular disease, more than double it. If you're an average smoker here, then 4.6 times the risk of heart disease, 3.2 times the risk of stroke. You'll quadruple your risk of death from vascular disease. So smoking is still key, and cessation works. If you look at people who stop, then their vascular risks very quickly approach those of the never smoker. So smoking kills, stopping works, even light smoking doubles your risk. Okay, that's done tobacco, one slide. What about blood pressure? Well, the Prospective Studies Collaboration took, I don't know why that's crept off the bottom of the screen. Anyway, they got data on 1 million adults based on about 60 different studies. It's Sarah Lewington's stuff. And when you get everything right, when you do the statistics right, then you finish up with a beautiful straight line relationship with 20 millimeters systolic blood pressure producing twofold differences in vascular mortality. Here's heart disease. So this is, again, 30-odd thousand heart attack deaths in 1 million people. And here's for people in their 40s, in their 50s, in their 60s. And these lines, this line is a 51% difference in risk for 20 millimeters. That line is a 50%. That line is 46. So these are all the way through the normal range, right from 110 to 190. That every 20 millimeters difference produces a twofold difference in risk. For stroke, it's even steeper, and for other vascular deaths, it's a little bit shallower, and for the aggregate of all vascular deaths, it's just the same as this. So for vascular mortality in middle age, 20 millimeters is a hard. So these are nice simple rules. Smoking, light smoking doubles, average smoking quadruples. Blood pressure, 20 millimeters halves your risk. What about cholesterol? Well, a good generic statin regimen, which is cheap, will knock about 2 millimoles off your LDL. Oh, of course, you're American, so that means 80 milligrams per deciliter, I think. That's about 80 milligrams per deciliter. But we do things in millimoles per litre. That'll knock about 40% off your vascular risk. And it does not affect non-vascular mortality. It doesn't affect cancer rates. It doesn't affect death rates from infection. You know, there's so much nonsense about side effects of statins, and most of it is just simply untrue. It's just as untrue as all the stuff about side effects of MMR vaccination. You know, they're safe, they're effective, and they're not used enough. Okay, so now we've done lipids. Well, what about being fat? Well, my body mass index is about 25, and I wish it was 23. So, you know, I've got a bit around here. But a bit lower, and I'd have slightly lower risk. But 25 is the conventional upper limit of normal weight and the lower limit of overweight. So I'm just on the boundary between normal weight and overweight as conventionally defined. And in the overweight range, you've got to actually go 10 units of BMI before you double risk. So you'd have to go from 25 like me to 35. That would be 40% increase in weight. You know, that is a lot of weight to be carrying around all the time. So, you know, it's quite difficult to produce twofold differences by loss of weight. It's difficult to do. Everybody thinks that losing weight is moral and taking pills isn't moral. I reckon what's moral is what works and avoids premature death. Anyway, here's the Prospective Studies Collaboration on weight. So BMI, I'm here. You lot are a little bit less than me, and I wish I was here. If I could lose 10%, I'd be down there. So that's the minimum mortality. And here, these lines are lines corresponding to 10 units of BMI producing a twofold difference in risk. You see, it fits the data pretty well. And now I'm going to show something which I'll ask you to treat confidentially until published. It's a paper which is in press. It's not my paper. It's a paper that's in press in the Lancet, which is called the Global BMI Consortium, and it just shows the data for men and women separately. And this is relative risk of death. This is in press in the Lancet. But this is 3.6 million adults, and they've done it really beautifully. They've missed out people who've got any disease to start with, and they've missed out the first 5 years of follow-up. They've even concentrated attention on the never smokers, where there's no possible mix-up of smoking being associated with in any way with BMI. So this is 3.6 million never smokers with no prior disease, you know, and so it's a beautiful result. And it's based on, you know, hundreds of thousands of deaths in 3.6 million adults, and the blue, the male, is here, and the red, female, there, and this is for all-cause mortality. So this is in press, and it's, please just leave it as confidential until published in the Lancet in the next month or two. But, okay, so it's steeper for males than for females. Again, not fair. Okay, and you know, adiposity, well, being too fat, it causes high blood pressure, it causes dyslipidemia, so we're double counting the story. And it also causes diabetes. And diabetes is very dangerous if it's incompetently treated. Diabetes which is properly treated is still dangerous. In America, you get diabetes and you'll finish up with about, you know, say 1.7 times the death rate of a non-diabetic, something like that, 1.7, 1.8. So, yeah, 70, 80% increase in the overall death rate. So it matters. And that's well-treated diabetes. Very well-treated diabetes might give you only, say, a 50% increase in death rate. Still, you don't want it. But incompetently treated diabetes will give you something like a 300% increase in your death rate. And if you look at diabetics, say Mexicans in the US and Mexicans in Mexico, then you get much higher death rates in the Mexicans in Mexico. They're much higher diabetic death rate ratios, because it isn't actually treated properly. You need outreach clinics that reach people. We've got treatments that work, and they're not really being delivered in many parts of the world. If you look in rural China, diabetes is much more dangerous in rural China than in urban China because it's less well managed. So the management of diabetes really matters. Treatment matters. We've got treatments that work. Okay. Now, time. I'm heading towards about the end of when I should be talking, so I'd better stop fairly soon. I've got some lovely pictures. Look, I've just some more lovely pictures, though. Look at that. That's American cancer mortality rates from 1950 to 2010. And there's lung. Now, on this scale, see, lung starts at 50, goes up to about 130, and then goes down. On that scale, the never smoker lung cancer rate is 7. So it would run something through the middle of the word stomach. So that's how much is added by smoking. So what's driving the causes, the trends? Well, lung cancer is still incurable now, just as it was in the 1950s in general. Yeah, a little bit curable, mostly not. And what's making it go down is people stopping smoking or not starting. Colorectal cancer, well, that is treatment. There you go. Treatment's helped there. Prostate cancer, again, treatment's helped. Stomach cancer, nobody really knows why it's gone down like this. It's decreased and we don't know why. And it used to be, right up here, it used to be the commonest neoplastic cause of death in the world back in the mid-century and beyond. And it used to be the commonest neoplastic cause of death in America. We don't know why it's gone down. I don't know. People tell me it's H. pylori, but I don't, really? I don't know. I just don't understand it. So I put it down as unknown. So lung is driven by cigarettes in the last 20 years, colorectal by treatment, stomach unknown. Here's women, different scale, incidentally, different scale. So look, here's 100 here, 150 there. When we go to women, we don't need to go up so high because they didn't have such high lung cancer rates. So just up to a rate of about 60, 70. And here's lung cancer in women, up and then down. Here's breast cancer in women, and that is better treatment. So lung in women, cigarettes. Breast, better treatment. Colorectal, well, it was going down anyway, but then it's probably been helped on down by treatment, so maybe it should have been here and now it's here. Uterus, particularly screening has been helpful. And then stomach, again, don't know why it's gone down. So, but if you try and take America and then say, well, what would we have seen in America if nobody had ever smoked? Then that's roughly what US cancer death rates ought to have been if nobody had ever smoked in males. And there's that little bit at the end due to better treatment. So there's the war on cancer. That's what the war on cancer has done in terms of treatment. I mean, if I had cancer, I wouldn't go to an epidemiologist. I'd go to a doctor and ask them to help me. I don't want to be rude about doctors, but I do want to be polite to epidemiologists. And this is what's been done by epidemiology, getting people to start smoking or not to start. And that's the big determinant of US male cancer death rates. Now in females, we've got a very nice trend which was going down, decrease in uterine cancer, and then has been helped on down by the great improvements in the treatment of breast cancer. So that's what female cancer mortality would have been doing if without smoking. That's what was added to it by smoking. It's still about a third. Smoking is still about a third of all the cancer deaths in the US. Still, as the epidemic's sort of changing. There's the delayed effects, the big uptake of smoking, first in men, then in women, and then there's the rather more rapid effects of the sudden decrease in smoking. Now, well, we can do the same thing for Britain, and it becomes a bit more extreme. So we had a worse epidemic than you did. And we can compare the breast cancer treatment rates in Britain and America. That's top is UK breast cancer death rates. Here's the US. But in both countries, treatment's doing quite a nice job. Overall, I think just continuing. I mean, what do? We continue with trying to improve treatment, and some of the stuff recently might turn out really to be breakthroughs. It always seems that there's a breakthrough coming in cancer research, in cancer treatment, and it may well be that there is now with these new efforts to get the immune system to attack your cancer. I don't know, but still, a third of all cancer deaths in the US are still from smoking, and if we could knock that down, then that is just something definite, and it doesn't need any speculation. There's lots of causes of cancer we can talk about. Chronic infection of one kind or another, diet, adiposity, environmental things, coal smoke, radiation, asbestos, but tobacco is still, it's still the biggest. It's about a quarter of all UK cancer deaths, about a third of all US cancer deaths. And, there's lung cancer versus the amount you smoke. Light smokers have 10 times the lung cancer rate of non-smokers. Average smokers have 20 times. Here's emphysema. Average smokers have about 30 times the emphysema death rate. So, it's not just vascular and cancer, it's emphysema as well. And also smoking increases death rates from TB and pneumonia, which are the two big causes of death in middle age. So, basically we need to take smoking seriously. Here's the Million Women study for all-cause mortality. Light smoking doubles your risk of death in middle age, all-cause mortality. Average smoking triples your risk of death in middle age. Stopping smoking works. So there's, if you stay stopped, there's 1.0 is the death rate among never smokers. 3.0 tripled is the death rate among average smokers. And here's for people who stop at 30 or who stop at 40. You stop at 40, yeah, you've always got a relative risk of 1.2, but you've got a 20% excess risk instead of a 200% excess risk. So you're avoiding 90% of the excess risk. Stopping works. It's better not to start. So what do you say? I don't know. I think we're going to get a lot of progress. This is UK cigarette consumption. US cigarette trends are even more striking. And, over the last 40 years, we've gone down from 9.6 to 3.2. There's where the Labour government put the price up in the 1940s. There's where the Conservative government put the price up in the 1980s. And when the price goes up, consumption goes down. Those are the biggest changes we got. And in South Africa and France, they tripled the price. They tripled the real price of smoking, so consumption went down by half. And what happened? The government took more money. They tripled the price, consumption went down, and the government real tax take doubled. So the government's got richer and we got fewer premature deaths. I wouldn't mind seeing that in China, actually. Basically, cigarette sales are going down in Western Europe and North America, but China, cigarette sales are still rising. I thought they'd stalled in the 1990s, but actually they've gone up a bit since then. And there's China. And just for comparison, in this year, which was China's famine year, when there wasn't very many cigarettes sold because they were dying of famine, that is actually something like UK cigarette consumption. So you can see how unimportant Britain is in comparison with China. And see how it's been rising. Anyway, we've done a couple of prospective studies in China, and the results basically show that male tobacco deaths are going up in China. It was 10% of the, jump one, it was 10% of the deaths in 1990, and it's about 20% of the adult male deaths in the 2010s. Meantime, the female deaths from smoking in China are going down because the old grannies who are older than me, the ones born in the 1930s, 10% of them used to smoke. But the mothers born in the 1960s, only 1% smoked. So we've got female smoking's gone down from 10% to 1% as you go from the generation born in the 1930s to the generation born in the 1960s. And even though they were smoking Chinese traditional pipes and things like that that aren't quite so good at killing you, nevertheless, they kill some women. And so Chinese female, it has gone down from about 3% of female deaths down to about 1 or 2%. It's heading for below 1% by 2030. Whereas in males, it's heading to over 30%, to about 30% in the 2030s. And with population growth as well, 1 million deaths 2010, 2 million deaths from tobacco in 2030, 3 million deaths from tobacco in 2050. Evolving epidemic and population growth. It's not just the evolved. So, Terry, what should I do now? Could I spend about 5 minutes belting through as fast as I can what remains, or should I give up and stop? What do you reckon? And should people feel free to do a runner if they want to? There was actually... Okay, well, there was some sort of structure to this. I haven't got to the end of where the structure was supposed to go to because I talked too much. So, okay, feel free to go if you want to, but worldwide, smoking is causing about 5 or 6 million deaths a year now. According to the Global Burden Disease, passive smoking is also causing about 0.6 million. I just do not believe it, but I just think passive smoking is grossly exaggerated. And that's about 1 million in China, 1 million in India. Now, this is now deaths at any age, not just under 70. If you were talking about under 70 deaths, you're probably talking about only 2 million, 1 million rich, 1 million poor. And as the statistic, and how many does that mean? Well, in 20 years, 5 million a year for 20 years is 100 million deaths. So in the first 2 decades of the century, something like 100 million deaths. With population growth and rising tobacco death rates in many parts of the world, going down here but going up in China, then probably about another 250 million over the next 30 years. It's about 8 million a year. And then more than 10 million a year in the second half of the century, because we've got 30 million new smokers a year. Most will keep smoking. More than half of all smokers get killed by it. So we're going to be running at more than 10 million deaths a year from smoking eventually. So these are very simple arguments. And they basically say about 1 billion tobacco deaths this century if we keep on the way we are, particularly if China keeps on the way it is, compared with about 100 million last century. It just seems ridiculous. So what can we do? Not only to get kids not to start, but at least get adults to stop. And if the kids see the adults struggling to stop, it may discourage them from starting. Anyway, the UN say that we're going to get 1/3 less smoking by 2030. Well, that's only 15 years from now. Are we? Well, at the moment, actually, worldwide cigarette consumption is probably rising rather than falling. It's going down in some countries, but going up in others. Worldwide, tobacco companies are bad people because they make $50 billion a year and they cause 5 million deaths a year. So that reckons that they reckon that our lives are worth about $10,000 each. But the governments, actually, they make 300 billion a year, so they make 6 times as much money as the companies do. If the real price stays constant and smoking does go down by 1/3, which is what the United Nations say they want to happen, then the governments are going to lose 100 billion a year. Well, that's not big money for governments, but it's not small. If, on the other hand, the real price doubles, that of itself will knock 1/3 off smoking, and it will mean the governments will make an extra 100 billion a year. I think that's not a realistic possibility. I think this is a realistic possibility. I would like the governments to be more greedy in terms of tobacco revenues. I would like them to put the price up and make more money, because I think if they don't do that, we are not going to get these reductions, and we're going to see these big increases in tobacco deaths that I've been talking about. So basically, things are getting better, except where they're getting worse. Death in old age is inevitable. Death before old age is not. I'm now down to the point where I've got 3 more slides I want to show. Okay, Terry? I'm pushing it, aren't I? Okay. Now, this is a scenario that will not happen. Death rates, remember, are going down. What if they stopped going down? What if the death rates of 2010 just froze? How many deaths would we get then before age 70? Well, the population's going up. So if, which will not happen, the world 2010 death rates froze all the way till 2030, and all we got was the population growth, then we'd finish up with about 44 million deaths before age 70. But now I come to the first decade of the century. What's been happening in the first decade of the century? Death rates have been falling. What happened between 2000 and 2010? Death rates from perinatal maternal communicable disease, they went down by 31% in the age range where they're common. It went down also in middle age, TB, pneumonia, things like that. But so they went down by 1/3. Deaths from non-communicable disease, the death rate went down 14-15%. Death rates from injuries went down by about 10-15%. So overall, under 50 mortality went down by 1/4, overall mortality at 50 to 69 went down by 15%. Well, if we could just keep that going, it won't keep going like that of its own accord. These are the results of very considerable efforts by international agencies, by governments, by people trying to get health insurance set up, by people getting vaccines distributed. And can we do better? Can we get better vaccination rates, better treatment rates? But it's a big effort. I mean, to keep going as well as we have would be an amazing achievement by 2030. But I think it might be in the sort of realistic range. Well, what would the numbers look like if the rates of decrease for each disease and in each age group and in each World Bank region in the first decade of the century, if they just kept on? Well, that's if nothing changes, we'll have 44 million deaths. And that's if the rates of decrease in the first decade of the century continued, then it'll be 30 million deaths. So it'll stay at 30 million deaths. Now that is a 1/3 reduction. It's not halving premature death, but it's a 1/3 reduction. It's a 1/3 reduction in premature death, comparing 2010 to 2030. And it's in a realistic range. It's in a realistic range if there's continued global commitment. Could we do even better than that? Can we do a little better than that? Could we keep blitzing on the things that were the targets of the Millennium Development Goals? Child survival, maternal mortality, HIV, malaria, TB. These were the Millennium Development Goals, and vaccination rates. These are the MDGs, supposed to be done between 2000 and 2015. Well, if we tried to push on those things, on those same targets, continue pushing on them, because we've already got the structures in place to keep pushing on them, perhaps we could get a reduction of 2/3, target a 2/3 reduction in them, and then a 1/3 reduction in the other causes. And a 1/3 reduction in these other causes is reasonable, given that we've got 14-15% per decade back in the first decade of the century. This is, in a way, a sort of optimistic, this is an optimistic scenario. If we really push on the MDGs and push on other things as well, maybe we can knock 40% off by 2030. And I think unrealistic is halving things by 2030. But if you say, could we halve premature death by 2040? Yeah, I think so, if we just keep on taking the big causes seriously. So I'd say 2030 no, 2040 yes. That would be my halving premature death, just in time for my 100th birthday. So here we are again. There, I'm going to be up there by 97 years old in 2040, and it would be nice if by then we could have got down from 54 to 36 to 18. So that's it, that's the target. Okay, good. Thanks very much indeed. Sorry it went on so long.
Richard, a tour de force, as always. You know, we have a small gift for you. This is very, just to remind you of your great participant. But the great thing is that those of you in the audience should appreciate that, as Dean Eric said, many of us believe that the greatest epidemiologist in the world. But the hard thing for all of you students,
Work out what you disagree with in what I said. There must have been a lot of things wrong in what I said. So don't let this be speaking from authority.
Right. That's the challenge: is to in your career prove or disprove all of the projections and the beauty of using the data. I think the greatest challenge that we all have is making our work have an impact.
Yeah.
And here's the model of someone who takes data and has an impact. So it's just remarkable to see.
What can I say? Come off it.
Well.
Anyway, what I've done in life, I just study the bleeding obvious. That's what I do. I just take the obvious things and do something on them. Get treatments given. Treatments don't work if they're not given. So that's it. Just anything.
Yes.
But if it's nice to have this as a big picture against which the various other things are playing out. You know, you can be we work on particular problems, but it's nice having this, bearing this in mind as a background. Overall, we're winning, but it takes lots and lots of little things to keep on winning. That's it. I don't know anything else.
Well, you totally changed my career in the 1980s when you came to NCI, when I was very early in my career, and you basically told me, keep it simple, keep your eye on the big picture. Don't get lost in the details. And You really, and you really did.
Thanks.
Give us. Well,
Okay.
For those of you, we have a reception across the hall, but we're.
Is this one of those government receptions where you're not allowed any wine?
No wine. Yeah. But we are also.
You'd never get away with that in Oxford.
I know. But we do want to have some Q&A. How would you like best to do that? We could bring.
Well, does anybody want to disagree with what I said?
Yeah. We can have a quick Q&A. We can have people to feel free to.
Well, I'm going to give quick A's anyway, just definitely. If there's if anybody wants to ask a Q.
And we can use the refreshment room and come back here for even more questions, probably, right?
I'll do whatever you say. Let's try the refreshment room anyway. Look, I don't know anything else. Yeah, please. What?
So your projections that we can maybe decrease mortality by 40% in this age range by 2030. What do you think about the rising social inequalities that we're seeing? And
Well, I think if you talk about, the question is about what, I'll repeat it for the web thing. The question is what about social inequalities and the differences between rich and poor? I think in absolute terms the differences between rich countries and poor countries are diminishing, as you've seen, so nationwide. And then within countries you've got differences between rich and poor. I want to know what drives those differences. You see, in Britain in the 1990s, if you looked at, say, death rates in, say, professionals and death rates in unskilled workers, the unskilled workers have much higher death rates than the professionals. And then you say, well, what's that due to? More than half of it was tobacco deaths. Now, as well as saying that the poor have higher death rates, why not say that most of that difference is tobacco deaths? Because you need to know what it is the poor are dying of. There's no point just saying it's because they're poor. What's doing it? In Russia, they say social stress caused this massive increase in mortality in Russia. Well, it's all very well saying social stress, but how did it do it? Well, it did it mainly by actually getting a vast increase in vodka consumption. And if you want to actually do something about those death rates, you want to know that. And, the poor in Britain back in the 19th century had much higher death rates, but, they just had the most incredible living conditions. I mean, the conditions, when I talk about 1 in 6 kids dying in Britain before their 5th birthday, if you go back to the middle of the 19th century, it would have been 1 in 3. But if you went to the East End of London, or Liverpool, or Glasgow, or the middle of Manchester, it would have been 1 in 2. And it's just the filthy conditions that they were living in. And as those conditions were improved, it actually benefited the poor more than it benefited the rich in absolute terms. Not necessarily in relative terms, but in absolute terms. So I think if you want to understand social inequalities, that you want to say what things are causing those social inequalities. And then you can say, why do the poor smoke more than the rich? Maybe they don't have that much of a feeling of a future to come. But what can you do about the fact that the poor smoke more than the rich? Well, get some things that seem to them to be relevant. And actually, one trivial thing, I know it sounds mean, but actually price has a bigger effect on the smoking of the poor than on the smoking of the rich. When you want to reduce the differences between rich and poor, get the price of cigarettes and spirits up.
It's one of the things that Tim McAfee and I have been saying, we're both still at Office of Smoking and Health, was that just putting a small amount of the extra revenue into preventive medicine types of programs for the low income makes it progressive, takes away the regressivity. So it takes it, so there's so much new revenue that just doing a few things like health clinics and other types of things.
I think outreach clinics can make a big difference.
Yes.
How do you get the things that work actually be given? I reckon that there's a general rule in it all that if you're way over time and nearly half the audience have walked out, then it's time to stop. So in abundance of that, I say we go out to the reception.
But we're available for more impersonal and other Q&A.